Topic of the lecture today is mucormycosis. Now, mucormycosis is actually a group of diseases. They can infect any of your system. They can infect your lungs. They can infect your skin. They can infect your brain, which is called rhinocerebral. They can disseminate into your blood. They can only involve the kidney, in which it's only isolated renal kidney syndrome, and other kind of modalities can come along with it. Now, mucormycosis is caused by what? Mucormycosis is actually a fungal infection which gets into your body and cause all of this pathology and affects all of these organs. Now, first of all, how does this organ get inside our system? It has three routes. It can get inside your system through inhalation, it can get inside your system through ingestion, or it can get inside your system through a break in your skin, or if you are subjected to some kind of trauma and you're exposed, or have you been exposed to any kind of burns recently, you're going to get this organism inside. Now, which of the organisms are responsible for causing mucormycosis? It's actually a class, an order of fungus which is called mucorales. Now, mucorales basically cause this pathology, but alongside with it, there are many other species too. There are many other fungi too. But what it does, what it causes, is that you can see proptosis of the eye cannot be even open in this situation. You can see this pathology. This is actually rhinocerebral. It will start from your nose. It will start from your nasal mucosa. It will make its way up to your cranium, to your brains, to your cerebrums, and then will infect different kind of arteries and vessels present inside the brain. It can affect your nerves which are coming around, and in turn, it will affect those organs which were supplied by those nerves. We'll talk about rhinocerebral in detail afterwards. Now, let's talk about etiology. What are the causative mucor species which cause this pathology, right? So first of all, we have rhizopus microspores. Now, among all the classes, among all the species of fungi which causes pathology, rhizopus microspores is on the top. In 70 to 80% of cerebral cases which are associated with this pathology, the causative organism is rhizopus microspores. Next on, we have rhizome mucor pusillus, which is also the causative organism. We have lichtheimia, corymbifera. Next on, we have Apophysis elegans. Next on, we have Corymbifera and other mucor species. Now, these species cause this pathology, cause mucormycosis. How does they get inside your system? We talked about it, through ingestion, through inhalation, or a break in your skin. Now, where they are found, where these species are found? They're found everywhere. They're found in the soil. They're found everywhere. You can even get them from a bread, from a molded bread. If you ingest that bread, you can get that. It's not like you're going to get that infection, because there are certain risk factors. There are certain risk factors which, if present inside your body, will lead to this pathology. Otherwise, you won't get this disease. This will be just cleared away. Now let's talk about those risk factors. Which risk factors will be causing this pathology? Which risk factors will be responsible for promoting this pathology inside your systems? So first of all, we have diabetic with DKA. What is DKA? Diabetic ketoacidosis. Now, if a patient presents to you who's suffering from diabetes, right, and he has presented to you with these symptoms, now let me tell you that patients which will present to you which are suffering from diabetes will always, if not always, in 70 to 80%, they're going to get rhinocerebral mucormycosis, right? So they're going to have those symptoms of headache, and that headache will be unilateral. It won't be bilateral, it will be unilateral. Now, when you ask that patient, how did it start? How did all of this pathology start? He'll tell you that it started with little nasal irritation. Then that nasal irritation became this black mold inside his nose. If you examine that patient back then, you'll find a black mold inside the nasal septum. Next on, what will happen? Next on, nasal congestion will happen. Next on, what will happen? Blood from one of the nostrils will come out. Not both the nostrils, one of the nostrils will come out. Right? And then it will go up. It will involve the superior orbital fissures. It will affect the nerves. When the nerves will be affected, what will happen then? When the nerves are affected, proptosis. Basically, does not start with proptosis, but when that nerve is affected and you cannot move that nerve, this leads to development of proptosis. Next on, what will happen? It involves what? It involves your brain. It involves the nerves coming out of it. It involves the vessels coming out of it. And basically, it involves the cerebral areas. So, the mortality rate in this pathology is about 50 to 60%. It means all the patients who got this rhinocerebral mucormycosis, more than half of them are dead. Despite the medical and surgical advances, this infection is contagious. This infection is very lethal. It might take your life, and you might not even know about that you have this infection. So, patients who are suffering from diabetes and presents to you with diabetic ketoacidosis, there are two possibilities. Either they develop rhinocerebral mucormycosis in the ketotic state, or they develop rhinocerebral mucormycosis and that ketotic outcome is just the outcome of this pathology. He's suffering from DKA just because of this rhinocerebral mucormycosis. So, if a patient is diabetic, he's definitely on the risk. He has to control his diabetes. He has to strictly control his diabetes in order to avoid such infection. Next on, we have hematopoietic stem cell transplantation. All the patients who went through stem cell transplantation, 2 to 3% of them have the chance of getting this infection. Because of what? Because they are immunocompromised. They are immunocompromised if this infection, if this organism gets its way into your system, gets its way into a person which just went through stem cell transplantation, it's definitely going to infect. And it's going to infect what? Now, that depends upon the circumstances of the patient, that depends upon the status of the patient, and that depends upon the immunity levels of the patient, how immunocompetent or how immunocompromised that patient is, and what the what was the route which was chosen by this infection. If it was coming through your skin, it's going to cause skin infections. If it's coming through your ingestion, it's going to cause GIT symptoms. Most probably, it's not like if it's ingested, it's going to cause only GIT symptoms, but most probably it will affect your GIT systems. And if it's inhaled, it will affect your lungs. And in all of these cases, if the patient was suffering from DKA2, it's going to affect your brain, it's going to affect your cranium, your meninges. That's what's called rhinocerebral mucormycosis. Next on, we have hyperglycemia. Why does hyperglycemia contribute towards the risk factors of mucormycosis? Because in hyperglycemia, you are actually providing that infection, you're actually providing that organism with all the things it needs, all the ammunition it needs to survive, to propagate. So hyperglycemia is one of those risk factors. Next on, we have defected phagocytic functions. If phagocytic functions are down, what's going to take care of all of these things? What's going to eat these things away? So defected phagocytic function is one of the leading risk factors in getting this pathology. Next on, we have elevated levels of iron. Now, you'll be hearing a lot about iron in this pathology and this infection. One thing you have to know is that This fungus grows on iron, aluminium, and glucose. Any disease, you can name it, any disease which causes the elevated levels of iron, aluminium, and we talked about it, glucose, any disease which causes these three to rise is actually aiding this infection, to propagate, to affect your whole body in a very small time. In a very small time, in a very minute time, they reproduce because they're getting iron, they're getting aluminium, they're getting glucose. They will reproduce, they will be more and more in number, and they will affect your organs. Basically, they are going to be those target organs we talked about. And I'm going to tell you when and under what conditions a patient get rhinocerebral, when and under what conditions patient is going to get pulmonary involvement, when and under what conditions patient is going to get skin involvement. We're going to talk about it later, but for now, elevated levels of iron are actually a direct relation of propagation of this disease inside of your body. It has a direct relation with that. If the contents of iron are more, it means that this infection is going to infect your body rapidly. Next on, we have solid organ transplantation. Solid organ transplantation, what does that mean? How does that affect your body? How does that bring that infection in your body? It's not like that the organ which is transplanted is taking this disease. No, it's not like that. It's actually when you go for any kind of organ transplantation, what you do is that you take heavy doses of steroids. You take heavy doses of steroids. You take heavy doses of immunosuppressants, so that your body won't reject the new organ. Your body won't reject this organ. You take down your immunity levels and you see if that organ is responding according to the body. If it is, everything is good. If it's not, it's an alarming sign. So when a patient is going to go for solid organ transplantation, that patient is given high doses of steroids and immunosuppressants. Both of them take the immunity down. When the immunity is down, what will happen? These opportunistic infections will get through your barriers, will go through your skin, or will go through your ingestion, or will go through your inhalation and cause this pathology. Next on, we have prolonged neutropenia. What does that mean? What is prolonged neutropenia? Prolonged neutropenia means any kind of chronic disease, any kind of chronic pathology which has affected your neutrophils, and the quantity and the number of neutrophils inside a body, which was supposed to be normal, was supposed to be between a range, is now low, is on the lower side. And what does these neutrophils do? They play a very important role in defending your body. They're actually the guards of your body. And these fungal infections, they're the first line of defense. If the first line of defense is down, it means they have a better chance of survival. It means these fungal infections have a better chance of survival inside of your body, and they have a better chance to cause this pathology in your systems. So patients who are suffering from prolonged neutropenia, which patients are going to be that? Basically, they're going to be patients which are suffering from cancer, which are suffering from chronic illnesses, which are suffering from this kind of pathology, which affect the neutrophils directly. All of these pathologies will lead to prolonged neutropenia. That prolonged neutropenia will take down the first line of defense, which is offered by the body. If any organism makes its way into your systems, this is the first line of defense. If first line of defense is compromised, what's going to happen? They're going to go through. And what's the second line of defense? This phagocytic activity. If that's also defected, now we're in trouble. Now we don't have any kind of defense present against that organism. And if we don't have any kind of defense, we will never be going to offense. We'll never be making antibodies against that. So they will definitely cause pathology in that person which is suffering from prolonged neutropenia, and alongside with it has this defective phagocytic function. Next on, we have malignancy. Now, most of the people will tell you that malignancy is one of the risk factors of causing mucormycosis, but I'll tell you that it's wrong. Actually, it's not the malignancy that causes mucormycosis. It's not. It's actually the treatment of malignancy. It's actually what comes after malignancy. You start the treatments. Treatments. What treatments do we start with? We start with chemotherapies. We start with radiotherapies. And the patients who are getting chemotherapy have a more and more chance of getting this pathology. Have more and more chance of getting this pathology. It means that malignancy is not causing mucormycosis, actually chemotherapy is. But as we cannot define that in the malignancy at what stage we're going to get mucormycosis, we just, for the sake of feasibility, we say that malignancy is going to cause mucormycosis. Next on, we have trauma with implantation of soil and vegetation. Now, what does that mean? We talked about there basically three routes of this infection getting into your systems. It was either inhalation or ingestion or through your skin. Which part of skin and when? That's what's written here. Trauma with implantation of soil and vegetation. If you have been subjected to some kind of trauma in which your body is exposed or your skin is removed or something like that happened, or any crack in your skin happened, and you were in contact with soil and vegetation or implantation, you're going to get this disease. It's more of a risk factor. And if your immunity is down at that level, if you're immunocompromised, if you're taking steroids, if you're suffering from diabetes, all of these risk factors we talked about earlier, if you went through hematopoietic stem cell transplantation, you have more and more chance of getting this pathology. Receiving antifungal prophylaxis. Now, what does that mean? I mean, if person is getting prophylactic treatments, it should not be that way. But it is that way, that body responds to these drugs, these prophylaxis. And what happens is that with time, tolerance develops. And when the tolerance develops, these drugs won't affect it that way, first of all. Second of all, these antifungal prophylaxis will somehow not affect these organisms and actually help them in propagation. Next on, we have catheter, subcutaneous injections, maceration of skin. Now, all of these infections, catheters, they are not clean. They're not cleaned properly. And if somehow they are in contact with this organism, and you insert that into a person, they're going to get this pathology. That infection is going to crawl up its way. Next on, we have subcutaneous injections. If it's not properly taken care of, and if the syringe is contaminated, first of all. Second of all, if it causes a break in your skin, and then you are subjected to this kind of environment with soil and vegetation, and you are subjected to this kind of environment, you're going to get this disease. Next on, maceration of skin is also one of the risk factors. Next on, we have busaconazole, which is also a treatment, which is also antifungal. If you're taking this drug, you're going to get this disease. It's also one of those risk factors. So if a patient is suffering from all of these, that patient is advised against taking the antifungal prophylaxis and busaconazole. Now let's talk about the pathogenesis. So in the pathogenesis, we're going to talk about the disease development, that how, if a patient is already suffering from a disease, already suffering from some kind of pathology, how does that develop into mucormycosis? How does that help out mucormycosis? It's actually an opportunistic infection. If there's any kind of other disease present in your system and it has your immunity lowered down, there's more and more chance of getting this disease. There's more and more chance of getting this pathology. So what happened that we have this end-stage renal disease? What happens in end-stage renal disease? You go for the treatment of defroxamine. What defroxamine does is that it chelates iron and it serves as fungal siderophores, which means that it's going to do what? It's going to actually deliver iron to mucorales And we talked about the what iron does. Iron actually helps this species. They feed on iron. They feed on aluminium. They feed on glucose. If these three factors are present, if any kind of disease, any kind of pathology leads to the rise of these three elements in your body, this infection will go very rapidly. This infection will infect your organs, go into dissemination and infect your systemic structures very rapidly. Next on, we have diabetic ketoacidosis. We talked about diabetic ketoacidosis in detail before that, but what's going to happen? It's going to cause metabolic or acidosis. It's going to cause what? Iron isolation from proteins in serum, and that iron will do what? That iron will help this fungus. They will feed on this iron and they will infect more and more. They'll reproduce very rapidly. Next on, we have hyperglycemia. What happens in hyperglycemia? Hyperglycation of iron sequestration proteins will happen. Upregulation of mammalian cell receptor will happen, and induction of defects in phagocytic function. We talked about in the risk factors that if somehow phagocytic function is compromised, it makes you more prone of getting this pathology. So these three different kind of systemic manifestations will lead to what? Mucormycosis. Under what conditions? If it's ancestral disease, it's providing this fungus with iron. If it's diabetic ketoacidosis, it's providing it with iron, and it increases fungal survival and virulence. And in hyperglycemia, we're having this defective phagocytic function. We talked about defective phagocytic function actually lowers down your immunity, and you're more prone of getting this disease. And there's more and more virulence, there's more survival rate of this fungus inside your body. Next on, clinical manifestation. It's actually divided into different categories. These categories are, first of all, we have rhino-orbital cerebral disease. Now, let's talk about rhino-orbital cerebral disease. Rhino means nose, orbital means your orbits, cerebral means your cerebral area. Now, all three areas are being affected in this category. That means it's going to be caused by what? We talked about rhizopus species. Rhizopus, in 70 to 80% of the cases, is causative organism for causing rhino-orbital cerebral disease. Now, let's talk about what happens in rhino-orbital cerebral disease. Why it's called rhino-orbital cerebral disease? Because the clinical manifestations that come along with it, those symptoms depict that these three are basic target structures. They're going to start from your nasal mucosa. You'll have this black fungus inside of your nasal mucosa growing up, and you won't even know about it. You'll have this sneezing. You'll have these episodes of sneezing afterwards. What happens? It's going to infect your mucosa. It's going to go up, and when it goes up at this level, you're going to get this bloody nose from one side, not from the both sides, one side. And it's not going to cause fever. One point to note is that fever is very late symptom in this pathology. So it goes up, it involves a superior orbital fissure, it affects the nerves, then goes into cerebral areas. It affects different kind of nerves, it affects different arteries, different veins, different structures. Now, when all of those are affected, what happens? Those clinical manifestations that come out are basically of proptosis, because optic nerve is affected, optic nerve is damaged. You're going to get this apoptosis of that eye. Second, you're going to have this bloody nose. Third, you're going to have these cerebral symptoms. And the mortality rate in this pathology is from 60 to 70%. All the patients who are going to get rhino-orbital cerebral disease are more than half of them are going to die. So even with the advancements, we don't have full control on this pathology because it's very late diagnosed. It's diagnosed very late in its progression. Now, as we were talking about, this is going to happen. We talked about orbital involvement. When superior orbital fissure is affected, this optic nerve is affected, you're going to get this pathology. Now, this is how it will look like. So that's why it's called rhino, meaning nose. When you look inside this patient's nose, you'll find the black mold. And this eye involvement causing orbital and then cerebral symptoms will be coming out. Next on, we have pulmonary disease. When are we going to get pulmonary disease? Now, before we move on to pulmonary disease, let me tell you that rhino-orbital cerebral disease often in 70 to 80% happens in patients with diabetes. Happens in patients with diabetes which are going under ketotic episode, which are going under diabetic ketoacidosis, right? So patients suffering from diabetes with diabetic ketoacidosis are more likely to get what? Rhino-orbital cerebral disease. On the other hand, when we talked about pulmonary disease is caused in those patients which are immunocompromised, or they're taking some kind of immunosuppressive drugs and the immunity is lowered down. And when the immunity is lowered down, they have more chance of getting this disease because this organism might go through inhalation to the lungs. And if the patient is immunocompromised or taking any immunosuppressant drugs, it means that patient is actually proning itself to that disease, actually giving himself or herself to that disease. That, okay, come in, cause me this pathology. Cause this pathology in my body. So those patients who are taking immunosuppressants, those patients who are immunocompromised, they ought to take very serious precautions in order to avoid this pathology because it has very high mortality rate. Now, as we've talked about which patients are going to get it, let's talk about what's going to happen in those patients. You're going to have chest discomfort, you're going to have cough, you're going to have wheeze, you're going to have all of those symptoms which you get in basically every pathology regarding pulmonary system. So how do we define that it's this mucormycosis? How do we know it's mucormycosis? You go for radiological findings. When you go for radiological findings, you'll find a halo sign. You will find a halo sign in your chest X-ray. Now that halo sign will tell you that it's mucormycosis. Now it's not like it's always going to be a halo sign. It can be the reverse halo sign too, right? So it can either be halo sign or it can be reverse halo sign. So radiological investigations will confirm that it's mucormycosis and not the other pulmonary manifestation, other pulmonary pathologies. As you can see, this is the involvement of the lungs. And here you will see at mostly it's in the mid-level and at the extremities, you'll find a halo sign right around here. Next on, you have gastrointestinal disease, right? Now, which patients are going to get gastrointestinal disease? Those patients which are malnourished, those patients which are severely malnourished, which are under protein energy malnutrition are going to get gastrointestinal disease. Somehow they're going to ingest this pathogen, immunity is down, they are malnourished, they don't have any chance of fighting that organism, and they're going to get this pathology one way or another. So what are the symptoms that will be coming along with this pathology? The patient will have all of those symptoms that usually occur in this kind of pathology and gastrointestinal diseases. This is going to infect your stomach, your ileum, your duodenum, right? These are the target structures in gastrointestinal disease. And patient will have these cramps, patient will have these pains coming out of its abdomen, the stomach pains. Sometimes it will lead to diarrhea, sometimes it will lead to nothing. So it will go on and on. It won't have any constitutional symptoms, right? Only thing that it has to confirm that it's that disease or it's mucormycosis biopsy. Next on, we have cutaneous disease. We talked about that the third route of transmission of this pathology is through what? Through breaking your skin, or if you were subjected to some kind of burn, or if you were subjected to some kind of trauma in which you were in contact with some kind of soil or implantation, right? So if there's any skin break, if there's any skin burn or something like that, you're going to get this cutaneous disease. Why cutaneous disease? Because it's going to infect, it's going to invade that local structure, and it's going to invade that local structure and cause this pathology. It can also cause granuloma, but mostly it causes necrotizing fasciitis. Remember that. It can cause granuloma, but it causes necrotizing fasciitis in most of the cases. Next on we have disseminated, in which it enters the blood, it goes to the blood. Happens very rarely, but happens, right? It goes into your blood and cause disseminated mucormycosis. And then that disseminated will lead to what? That disseminated will lead to this rhino-orbital cerebral disease, or it may only affect your brain, it may only affect your central nervous system structures, right? Next on we have miscellaneous, in which any of the other organs or any of the other sites can be infected by this pathology, and the outcomes and the clinical manifestations will be dependent upon which part or which structures are being involved. Now let's talk about the categories. Rhino-orbital cerebral disease, we talked about it. It's going to cause what? It's going to cause eye and facial pain, right? Next on, we'll have this conjunctival suffusion. Next on, we have this blurry vision. Next on, we'll have this facial numbness. These are the initial symptoms of this pathology. You're going to get this eye and facial pain, conjunctival suffusion, then blurry vision, then facial numbness. This blurry vision because optic nerve is being affected. Facial numbness because now the whole nerve path is being blocked. Now the whole nerve path is being compromised. You'll have this facial numbness. Next on, let's talk about the pulmonary disease. What symptoms the pulmonary disease will manifest with? First of all, you'll have this dyspnea, right? Second of all, you'll have this cough. Third of all, you'll have this halo signs within the lungs. These isolated masses will be seen, and there will be lobular in consolidation with cavitations, right? Fourth, you'll have hemoptysis in this patient. So in the patients which has this pulmonary manifestation, pulmonary disease, we talked about, it's going to be immunocompromised patient. It's never going to be immunocompetent patient, right? So this immunocompromised patient has got this disease. They'll start with dyspnea, they'll start with cough, but it's normal, right? In our societies, in cold, we get this pathology, we get coughing and sputums and everything. But what we don't get is within the lungs, when we go for etiological manifestation, isolated masses with lobular consolidation and cavitations. And second of all, you don't get hemoptysis in every case which is related to pulmonary pathology, right? So this will be the outlook of pulmonary disease. Next on, we have gastrointestinal disease. Gastrointestinal disease will present with abdominal pain. Next on, we'll start with vomiting, nausea, and distension, right? So all of these will be seen in gastrointestinal disease, gastrointestinal pathology. We talked about gastrointestinal pathology will be happening in those patients which are malnourished, which are protein energy malnourished. Next on, you have cutaneous diseases. In the cutaneous diseases, we have necrotizing fasciitis. You can see the necrotizing fasciitis right here. We talked about it because it can cause granuloma, but when it invades your skin, it definitely causes what? It definitely causes necrotizing fasciitis. And next on, we have necrotic cutaneous lesions will be found. This is what it will look like. Necrotic cutaneous lesions will be found between these fingers, between these digits, and it can occur on the surface too. Next on, we have this disseminated disease. In the disseminated disease, what will happen? It will infect your brain. Common site is brain. Next on, it's going to do what? Mortality rate is 100%. It's not going to let that person go. If it gets to your blood, it's not going to let that go. It's not going to let that person live in any case. It's going to infect your brain and it's going to cause death mortality rate in mucormycosis is 50 to 60%. But in the mucormycosis, if it goes into dissemination, the mortality rate is 100%. Next on, we have miscellaneous diseases which are associated with mucormycosis. We'll have these joint pains, basically the hip joint pains. We have this isolated nephrotic, or isolated kidney syndrome, in which only the kidneys are affected, and we don't know what caused that. Some theories are here that it happens through urinary infection, it makes its way up, it crawls its way up. Some theories say that it's happening because of dissemination, and brain is not the only target organ in dissemination. It might affect your kidneys, but for sure, we don't know what theory is right and what pathogenesis is right regarding isolated nephrotic kidney disease, regarding mucormycosis. Next on, it can affect your lungs, and it can affect the structures surrounding your lungs. Now, diagnosis. Let's talk about the diagnosis. How are we going to confirm our diagnosis? Because we talked about which organs are being affected, right? And all of those organs are being affected on daily basis in different diseases. So how will we know that it's mucormycosis before it's too late, right? So first of all, the definite diagnostic modality you'll go for is positive culture. Is a culture actually which will show positive culture from sterile site. If it's giving you that, it's definitive diagnosis. Next on, we'll go for the visualization by acid shift or methamine silver stain. We'll go for the culture with that. Next on, you'll have it biopsy with histopathological examination. Now, biopsy is actually the gold standard here. Biopsy is the gold standard here, because most of the cultures won't be coming positive. Now, in the books you'll read, the culture is the basic test. The culture has to be positive, but no. In 50 to 60% cases, culture does not come positive. It always comes negative. What do we do then? We go for the biopsy. Biopsy is the gold standard. Biopsy is the test you look forward to. Biopsy is the test you relate your treatment with, right? Next on, you have this more than 6 to 30 micrometer cell thick walled ribbon hyphae branching at right angles. Now, what's it seen with? It's seen with microscope. It's a microscopic picture, right? So this is a diagnostic point for you that you'll see more than 6 to 30 cells, right? 30 micrometer cells, ribbon hyphae branching at the right angles. Now, these are the different ways you can confirm your diagnosis, but still, the gold standard for your diagnosis is biopsy. Now, therapy or treatment. How do we start the treatment of this patient? Now, we have talked about the mortality rate, right? Now we'll give it a minute. That how this treatment will be going through, how this treatment will be carried out. The treatment depends upon the causative organism. First of all, you went for your biopsies, your cultures, you got the organism that, okay, this species is causing this pathology. You'll go for that antifungal, right? But it's also possible that you cannot do that. In what cases? In necrotizing fasciitis, you cannot go for antifungals and expect that everything will be all right after giving antifungals. No, you won't be expecting that, right? So what do you go for? You go and treat this patient according to the symptomatology. If only effect or only place or only site of infection is a skin or a part of skin, you may go on and remove that area, right? Antifungals won't do anything. That area is already necrosed. And that's first modality. What's second modality? We have to exclude the risk factors. If it's a diabetic patient, we're going to ask that patient to keep its sugar levels in check. Don't develop DKA again, right? Don't develop hyperglycemia again. If it's Any patient which is suffering from chronic kidney disease, we're going to ask that patient to take some drug which won't chelate iron and provide antifungals with more nourishments and more stuff. Right? Number 3, if any patient is subjected to some kind of hospital environment which was contaminated with antifungals, when is that going to happen? If a burn patient comes to you with all the stickings around that burnt area and you remove it, there's some kind of mold on it, it's definitely going to cause this pathology if it gets inside the systems, right? You have to avoid that. So first of all, you'll remove the risk factors, all of them, if you can, if you may. You remove the risk factors, then you go for the treatment. Now the treatment of rhino-orbital cerebral pathology, pulmonary pathology, gastrointestinal pathology, do you think the treatments will be different? No. Symptomatology and the symptomatic treatment will be different. If a patient is going to have headaches, you're going to treat headaches. We're going to give treatment for treatment for headaches, right? But it's not the basic treatment of this pathology, right? You treat the symptomatology and then you treat this pathology. So what therapy or treatment is important? First of all, in general principles, you're going to go for the early diagnosis. You have to diagnose the patient early. You have to look for the danger signs. And if this patient has these danger signs, you go for the definitive diagnostic modalities. Next on, we have this reversal of underlying predisposing risk factors. We talked about it. We will try and remove these risk factors as much as possible. And if it's some kind of cutaneous modality or infection of the skin or some kind of pathology which occurred just on the skin, you can go for the surgical debridement of that place. Next on, you go for the antifungal therapy. Now, antifungal therapy is the gold standard treatment, obviously, and you go for which antifungals? Let's talk about those antifungals. First of all, the therapy starts with primary antifungals and primary combinations. Primary antifungals are what? Amphotericin B. Next on, we have liposomal amphotericin B. Next on, we have amphotericin B lipid complex. Now, these are primary antifungals, and you might go for them. But these days, we have these primary combinations present, which are caspofungin plus lipid polyene. Next on, we have micafungin plus lipid polyene. Now, these are the primary antifungals that you'll prescribe, and these are the primary combinations that you'll prescribe. Now, whether to give primary antifungals or combination drugs depends upon the severity of the disease and depends upon the involvement of the disease, depends upon the involvement of this pathogenesis, this pathology, right? So it's not like you're going to only focus on these medicines. You're going to start with removing the risk factors, first of all. Then you will go for other modalities, other symptoms that patient is going to get. You'll remove that symptomatology, you'll treat that symptomatology, and then you'll go for these antifungals. Now that's all for this lecture. That's all for mucormycosis. What points you have to take home is that you have to know which organism and which class causes this pathology. We talked about it. Next on, you have to know the risk factors, that these risk factors are important and they are going to cause this pathology and how. Next on, we talked about what pathogenesis is, and in different kind of other pathologies, how those pathologies lead to mucormycosis. Then we talked about how we diagnose it. We talked about the different types of it, the clinical manifestations of it, and then we talked about removing those risk factors and treating the patient. Now that's all for today. Thank you for watching sqadia.com.